Thank you very much, and good morning, everyone. Firstly, I would like to thank the Oxytocin Initiative and MCHIP for getting me here. This is my very first opportunity to visit Bangladesh, and thank the organizing committee to give me the opportunity to speak to so many people at the same time. And I really, as mentioned, I'm an obstetrician working in the Eastern Cape, but also with an interest in clinical trials and systematic reviews. And today I'm speaking on behalf of a big group of people, colleagues of ours who are involved in large randomized trials, which, as you know, can only be a huge collaborative effort from many people in many countries. And it is on behalf of these people that I'm speaking. So why did we undertake this trial of looking specifically at controlled cord traction as one of the components of active management of third stage of labor? Jean-Paul mentioned that the previous WHO recommendations recommended active management of third stage of labor as a composite intervention, but conceded that there was not good evidence about the individual contribution of each component. And this trial was specifically directed at defining the contribution or lack of contribution of controlled cord traction as a component of active management of third stage of labor. And this is a very important question because controlled cord traction requires specific skills and specific training, and it does carry certain risks. And therefore, if it's not really important, it would be good if it were possible, as you now know. Unfortunately, having heard the other talk, you already know the outcome of the trial. If we could not make it an essential part of the recommendation. So we know the main risk is that if you pull too early, you invert the uterus. This is an inside-out uterus, and you can see we're infusing saline into the vagina around the uterus to reduce it, and there you can see it's popped back into its normal position. So inversion of the uterus is one of the main risks if controlled cord traction is not done skillfully. We conducted a systematic review, and there was only one previous trial, Fernando Altabia's group, which was much too small to give us any useful information on the value of controlled cord traction as an isolated intervention. And therefore, we felt it was justified to mount a large trial. And the primary objective of this trial was to determine whether a simplified package using oxytocin but no controlled cord traction was not meaningfully less effective than the full package. And the primary outcome was severe postpartum hemorrhage, in other words, 1,000 mils or more of measured blood loss. And our hypothesis was a non-inferiority one. So we were wanting to show that the simplified package, or wanting to see whether the simplified package was not meaningfully less effective than the full package. So the study design is there to see. Several countries were involved. The participants were women who were in labor and expected to give birth vaginally, and they were randomly allocated to two groups. The simplified package was regarded as the experimental group, in which oxytocin was given, but controlled cord traction was not used. The placenta was allowed to deliver spontaneously. The control group was the full package, including controlled cord traction. The primary outcome, as I mentioned, was measured blood loss of 1,000 mils or more within an hour, using a plastic drape which was tied around the mother, so they really collected all the bleeding after childbirth and was then weighed. The protocol was registered and was published prior to the trial. The baseline characteristics of the women, which always happens when you do a proper randomized trial of this magnitude, were identical, absolutely the same. So we about 11,000+ women in each group, absolutely identical at the time of randomization. The adherence to the trial intervention was good in terms of the allocated use of controlled contraction or non-use. Adherence was about 95% in both groups. More than 99% of all women received oxytocin, and about 78% received uterine massage. The trial outcomes. We will focus on the primary outcomes. So what you can see is that the blood loss greater than 1,000 mils was very slightly greater, about 9%, the point estimate in the experimental group, that was the simplified package group, and that the 95% upper limit of the 95% confidence interval was just about at our pre-specified upper limit of 30%. And so our results were in fact borderline for achieving our specified definition of non-inferiority for the simplified package. The actual volume of blood loss lost on average the difference was very small, about 10 mils more blood loss on average with the simplified package. In our initial analysis, there was a significant increase in retained placenta in the simplified group. However, this increase was almost entirely limited to one country, the Philippines, and when we looked into it, there was a large amount of use of ergometrin in this country. And so we did a secondary analysis excluding the Philippines, and in that analysis there was absolutely no difference in the incidence of retained placenta. And so this was a very important finding, that if one's using ergometrin as the uterotonic, then not using controlled cord traction is associated with an increase in retained placenta. But with oxytocin, there was no increase. And this is just to show graphically that the point estimate was about a 9% increase in PPH, and the upper limit of the 95% confidence interval just crossed over the threshold of a 30% increase. So when we added the result of this trial to our systematic review, of course it swamped the previous trial, and the results of the systematic review are more or less the same as of the trial. Here you will see things are swapped around so that controlled cord traction is shown as the intervention, and controlled cord traction is not associated with a significant reduction in postpartum hemorrhage in the systematic review. So the main findings in summary are that controlled cord traction adds minimal value to the package of active management of third stage of labor, and that oxytocin, 10 international units after delivery, should remain the mainstay of management of the third stage of labor. In settings where skilled birth attendants are not available and oxytocin is used, it is quite safe and reasonable to omit the use of controlled cord traction. In settings where skilled birth attendants are available, the use of controlled cord traction is really optional. It is not essential. It does result in some shortening of the third stage of labor. It may be seen as convenient, particularly in very busy labor wards where there's a high turnover, and midwives have many other duties and need to get on with other duties. There's no reason they should not use controlled cord traction to speed up delivery of the placenta. But it should not be assumed that this is conferring major clinical benefits. It's important to remember that even if one decides not to use controlled cord traction, in our trial, 6% of women did require controlled cord traction, so it remains an extremely important skill which should be in the training. And in a way, one should not completely forget about it, because if it's not being used, midwives will lose the skill. and when it's needed may not have that skill. So it's an important skill to be kept for when it is needed. However, it is a procedure which can be dispensed with without major loss. And finally, and I'm well within time because we've just seen 5 minutes, the implications for research. The findings of this trial obviously strengthen the need to focus on operational research to find how we can succeed in ensuring that all women have access to oxytocin at the time of birth as being the most effective method of preventing postpartum hemorrhage. And the other component of active management of third stage of labor, which has not yet been well studied, is uterine massage. And that's a very important intervention to be studied, because if one is without anything, if one has no uterotonic, in fact, uterine massage is the only method available. And it's important that we do research to determine the effectiveness or otherwise of this intervention. Thank you very much.